Welcome to this episode of CGTN Special COVID-19 Frontline, and we are bringing you this live from Wuhan, the epicenter of the COVID-19 outbreak right here in China. And since mid-March, CGTN have been holding similar online consultations, and joined by doctors from both Wuhan and overseas. And they've been sharing their experiences and knowledge accumulated about this virus, so that they can have a better understanding of the virus, and they can help to better fight a better battle against COVID-19. And I am CGTN's Xu Xingchen. And we're not talking about just saving people's lives here. We're also talking about ways to offer protections to medical staff. And they are the last defense between the virus and humanity. And today we're joined by Dr. Peng Zhiyong from Zhongnan Hospital of Wuhan University. And he has been battling the virus since the very start. And in fact, Dr. Peng, you are one of the very first doctors to join our session. And also on the other side of the line, we have doctors from the US, from the National Institute of Health joining us for this discussion. But you guys are the professionals, and I think I'm just going to leave it to you guys and to share what you have prepared to share with each other. Dr. Peng.
Okay, thank you. Okay, so now can we start? Okay, sorry for the delay. So today I will briefly talk about what we learned from COVID-19 outbreak in Wuhan. And I will briefly talk about the general features of the COVID-19 and the strategies of innovation for the COVID-19, and also the key points of the ventilation support for the patients. So first, I will briefly talk about the basic features of the COVID-19 patients. So the age, including age and the comorbidities, and most of the patients relatively older and much more comorbidities, including the hypertension, diabetes, and the cardiovascular diseases. And also the most common symptoms, including the fever, fatigue, dry cough, myalgia, and dyspnea. Also, the clinical process, the time from the first symptom to the dyspnea was around 5 days. 7 days to hospital admission, 8 days to the ARDS development. And the typical lab test is lymphopenia and elevated LDH. The typical chest CT is ground glass opacity, initially from the peripheral area of the lungs. The typical features for the patients in the ICU. Here, the score, so SOFA score, average score, actually not so high. However, the people ratio is quite low. It's around 130 in our patients in the ICU. And the most common complications for the patients in the ICU, including ARDS, acute cardiac injury, and shock. The most common ventilation supports almost half of the patients requiring intubation, and some of them switch to ECMO. So next, I will briefly talk about the strategies for the critical intubation for the patients. So first, before the intubation, we needed to prepare, including the PPE, including the personnel, all the personnel requiring the PPE training, and also they are also familiar with the medical history and airway conditions of the patients, and they are all experienced providers for the intubation. Also, we need to prepare for the backup plan for the patients, for the intubation. So for the basic PPE for the during the intubation, including the surgical gloves, the gowns, the eye protection, the N95 mask, goggles, also hood, if possible. So during intubation, we need to also prepare for the pre-oxygenation at least for 5 minutes with the 100% of oxygen. Also, if possible, we give bolus of 200 ml of fluid. Also prepare the prophylaxis of vasopressors to prevent hypotension during the intubation. Also, for the medication, we use indomitate, calamine, midazolam, rather than propofol for the induction. Also, we use rocanolium for the used as the muscular relaxants. So during the intubation, so we try one attempt. So we use the video laryngoscope for the intubation. Also, we prepare some airway device backup. So after intubation, we also confirm the placement of the tubing as usual, and also after the intubation, we also prepare the PPE. We take off the PPE also for the hand hygiene. So this is very very useful protocols for the intubation procedures. So here we also summarize the cases of intubation we have done. Actually, we have done about nearly 200 cases for the intubation. So so for the PPE, most of them using the N95 mask, and also surgical mask, also goggles, and face shield. So using this PPE, no any personnel infected by the COVID-19. So this is a very good protection for our medical professionals during the intubation. Also, we check up we measure the hemodynamics during the intubation. Actually, most of the patients complicated with hypotension. So also complicated with the hypoxemia. So we think that the pre-oxygenation, so not enough for 5 minutes. So if possible, we prepare for longer time for the pre-oxygenation. Also, because almost half of the patients complicated with hypotension. So we suggest to give at least 250 ml bolus of fluid prior to the intubation. So also prepare the vasopressors to prevent hypotension. Also try to avoid the propofol, because propofol will inhibit the cardiovascular system. So this is our experience for the intubation. And also 5 patients died, complicated with the cardiac arrest during the intubation. So which indicated so the hypoxemia, the management of hypoxemia is quite important during the procedure of the intubation. So here we emphasize that the hypoxemia and the circulation collapse probably happened during the intubation for the patients with the COVID-19. So we should be careful about that. So the last, I will briefly talk about the key points of the ventilation supports for the patients. So non-protective approach is extremely important for these patients. Prolong the patients as early as possible. So evaluate the modes, the parameters we set frequently. So switch or change if not appropriate. So titrate PEEP and the tidal volume based on the transpulmonary pressure, if possible, or driving pressure. Keep the driving pressure less than 15. Prevent equitable pulmonary, which is always happened in the patient with the COVID-19. Also induced by the severe hypoxemia and subsequently severe pulmonary hypertension. So be careful of the lung recruitment maneuver. Set the highest PEEP at 20, because the high PEEP will induce pneumothorax for the patients. And also, we have the flow chart for the patients using the ventilation strategy. So based on the PEEP ratio, so if the PEEP ratio is 200 to 300, we can try high flow nasal cannulation. But here, I recommend the high flow used in the ICU environment designed with the negative pressure. So if the ICU environment without the negative pressure, probably the high flow will induce the pollution by the virus. And also we monitored the virus level in the different ICU environment. And also we found that we can find the positive virus in the air, in the surface of the ICU equipment, if without the negative pressure design. So we evaluate the efficacy for all the non-invasive ventilation based on the LOXI score. LOXI score is calculated from the respiratory rate, saturation, and also FiO2. So if the LOXI score more than 3 points, so we think that ventilation probably works. If less than 2.8, so we need to switch to another ventilation supports. So for the non-invasive ventilation, we should be careful about the BiPAP probably worsen the lung injury. So evaluate the tidal volume when you're using the non-invasive ventilation. So if the tidal volume less than 9 ml per kilo continue, if more than 12, intubate the patient. So if the PEEP ratio is less than 150, so we prefer intubation the patients. So also we need to evaluate the patient is response to the non-recruitment maneuver. So also if the driving pressure is quite high. We need to paralyze the patients, also with the prone position. And also we follow up the lung compliance. So if the patient's PFO ratio still low, and also complicated with the acidosis and hypercapnia, and we need to switch to the ECMO for the patients. So actually here, I also share a case report for you, but because you cannot see the PPT, it's difficult for me to show the case report. And I mean, the lessons we learned from this case. So it's if the non-invasive ventilation lasted longer time, probably would worsen the lung injury. So this lady received non-invasive ventilation in another hospital for almost 9 days, and when she came to our ICU, she is the severe.
She can not see the patient. No, I just wanted to know if you had things before, like fentanyl and or two. Yeah.
Okay, so this patient, when she came to our ICU, she's extremely hypoxemia, and we intubated her, but only for a short time. Her condition become deteriorated, and then we switched to ECMO for her. So after 9 days of ECMO treatment, so she finally went off from the ECMO, and another 5 days, she finally went off from the ventilators. So here I summarized my talk. So the the critical ER patients tend to be older with more comorbidities and laboratory abnormalities. So preparation of PPE and pragmatic protocol during the intubation is important to prevent transmission, prolonged pre-oxygenation, and the bolus of fluids, as well as the vessel pressures were required to prevent hypoxemia and circulatory collapse during intubation. So titrating the both parameters of ventilation support with non-protective approach is very important. The most common complications was ARDS, arrhythmia, and septic shock. Nearly half of the patients in our ICU required invasive ventilation. So thank you all for your attention. Thank you for inviting me. I'm happy to take any questions from you.
Thank you very much for this presentation. Anybody who's on the line, please turn your phone to mute. Thank you.
Dr. Miller. Dr. Miller is have the phone. I just passed it.
All right. I have a question. What percentage of your patients that were ventilators respirating and ECMO?
Okay, you mean what percentage of the patients using intubation finally switch to ECMO, right?
Yes.
Okay. I mean, almost 1/4 of the patients with intubation finally switched to the ECMO in our ICU.
Was there any similarity of any of the patients that died during intubation or reflected with anything?
So, sorry, can you say again?
You described 5 patients that died in intubation.
Oh, intubation. No, it's the cardiac arrest. Cardiac arrest during the intubation. It's not the because this is the big database. It's the around 200 patients from 2 hospitals. So I mean, 5 of the patients complicated with cardiac arrest during intubation. Was
there anything about 5 patients that would make you believe there's something that put where you're missing?
Do a lot of echoes.
Yeah, a lot of echo. I cannot hear clearly.
Dr. Miao, why don't you repeat the question? Maybe it'll be better.
I can't hear you either. Can somebody just type on the screen? Type on the screen. Either one more time.
Okay.
It might help if you pick up the phone and try to speak.
Okay. Of the 5 that had a cardiac arrest during intubation, was there anything specific about or in common that would make you about any specific patient?
So basically, we are experiencing these technical problems about these teleconference application. But anyways, they're trying to short out their ends. So basically, we had Dr. Peng from Zhongnan Hospital of Wuhan University did this 20-minute presentation about what he found during his treatment during the past almost 100 days, over 100 days. And share what he found about treating coronavirus COVID-19 patients. And the doctors from the United States, they've been questioning like how many patients have been switched from a ventilator to ECMO. ECMO is one of those machines to pump blood and out of human to help oxygenate. And they also want to know more about this kind of the death problem during incubation. And according to Dr. Peng, some of the patients experienced cardiovascular arrest during the incubation, but it is still not it's not a significant, a huge rate, a huge number. And anyways, so if you have any questions, you can leave comments on our Facebook, Twitter, or even Weibo, and we can try to answer some of those questions later through this live stream. And probably we're just going to get back to this their teleconference, because Dr. Peng, we can see question right here. Someone posed this question. I'm going to read out this question. How severe and what is the mechanism of the cardiac and GI involvement and injury? Can you answer that question for them first?
Okay. So here I saw a question about how severe and what is the mechanism of the cardiac and GI involvement in injury. Is any direct injury from virus or sequencing of ARDS with oxygen demand or the outweighing supply? Are there any certain pressures that work better than others for this specific patients? So I think for the patients are developed cardiac arrest during the intubation, I think probably is due to the severe hypoxemia, and this kind of patients actually they have hypoxemia for a long time, and also we found a phenomena that there's no I mean there's the we all know that they have the association between the pulse oxygenation and also the oxygen content in the blood. So, for example, if the pulse saturation is around 93%, it means the PO2 is around 70 millimole mercury. But however, in some patients, we found that the saturation is 92%. But however, the PO2 is only 40. So this is a very specific problem. We don't know how this happened. And also we checked the pH. pH is okay. We also checked the hemoglobin. Hemoglobin is okay. So this is the specific. This is the bizarre phenomenon. We don't know. So probably is the patient shows okay, his saturation is okay. Actually, his oxygen in the blood, oxygen level in the blood is quite low. So I mean, this patient is need a longer time for the pre-oxygenation. So before intubation. So if the pre-oxygenation time is shorter, probably we are induced the hypoxemia during the intubation.
And we can also see someone asked, was there anything in common with the 5 patients that had cardiovascular arrest that we should look out for? That's the patients you mentioned about. They experience this complication during the incubation.
I mean, it's the not only for the for the oxygenation, but also for the blood pressure. Also, this kind of patients is easily to have hypotension. So why we need to give some bolus of fluid before intubation? So I mean, if the patient had severe hypoxemia and also have severe hypotension, it's easily to induce the cardiac arrest. So we should be careful about both situations.
And what about other ways? Because someone also asked, did you employ other
Okay, actually we haven't used the nitric oxide for the patients with the pulmonary hypertension, but we do prolong the patients. Almost for all the patients, we prolong the patients. We prolong the patients as early as possible, as soon as possible. So even the patient came to ICU without intubation, no need for intubation. Also, we prolong the patients earlier, and also is the need time to see the improvement of the oxygenation when you prolong the patients. So for the ARDS, from other etiologies, when you prolong the patients, you can easily to see the oxygenation improvement when you prolong the patients. But for this kind of patients induced by the COVID-19, it's in this time, probably need a couple hours to see the improvement of the oxygenation when you prolong the patient. Okay. Yes, I think that we use the prone position to improve the shunting, the shunting, the vacuum mismatch, induce the shunt. And for the innovation, of course, we use the N95 as well as the hood with the PPAP, with the positive lecture. So the patients, complicated with the arrhythmia and as well as the hypertension prior to the cardiac arrest. So arrhythmia also very common in the patients in the ICU. I have a report that almost 40 of the patients complicated with the arrhythmia. So because we haven't such equipment to use the nitric oxide in our hospital, and also I think in the whole Hubei province, there's no any hospital using nitric oxide.
So Dr. Peng, because I've heard a lot of really difficult terms. So because from the States, they've asked during the incubation, should they use N95 masks or PAR PARPs? So what is a PARP?
PAR is the we wear the hood.
Oh,
the hood.
The facial.
Yeah, the hood cover everything, cover your head.
Oh, okay.
Also with the positive pressure inside. Yeah, so that which is called PRs.
Oh, so is it the more higher end protective suit?
Yeah.
Okay.
High level of the personal protection.
Mm-hmm. So there someone is typing there. Let's see. So Dr. Andrew Mays from the National Institute of Health has a few questions
long-term
here.
effects.
Yeah.
Okay. Long-term effects. Okay.
After recovery. Yeah,
Okay.
Long-term effects after recovery.
So actually, for our patient in our ICU, I just mentioned that the mortality in our ICU is around 25% to 30%, and also we are following up the patients from discharged from our ICU. So now it's almost the first 3 months for the patient. The discharged, from a hospital, from ICU, and also we are following up now. We hope we can get some information, and to provide some useful information for you. But I don't know what is the long-term effects. Probably I think it's the. I also follow up our patient received the ECMO. Actually, he was good. He is good now. What is arrhythmia? It's the AF. AF is very common for the the arrhythmia.
Let's go back to the mainstream. There are some others ask, what medication are you using to keep these incubated patients sedated?
Okay, sedated. Okay. So we use the midazolam for the sedation for our patients, because this kind of the sedation no any effects on the cardiovascular system.
Were you using ARDS NAT protocols for ventilation or APRV mode?
We use the ARDS NAT protocols, for the patient.
Let's see what Ling has here. Among all these patients on ECMO, what is the percentage of the survival rate?
So I mean, the survival rate is we just summarize the result from our data. So I mean, the overall survival rate is around is around 40%. 40%. So so far we have performed almost 20 ECMO for our patients, but only 9 patients survived to the survived and discharged to discharged to home.
Let's see, Dr. Meng.
Okay. Yeah, this is the pulmonary emboli. Pulmonary. Yeah, this is the also. I mean, we also follow up the DVT using the echo. We find almost half of the patients had DVT in our patients, and but so far we found 2 patients complicated with the PE, but not so severe, not so severe. But so we routinely use the heparin for this kind of patients.
Is that like pressure control or volume control? I think that's for.
Well, initially we use the volume control for our patients.
They have. How do you treat? I cannot.
Cytokine storms. Cytokine storms, and cytokine storm is the. We use the the monoclonal antibody, or we using the blood purification to treat the patients with cytokine storms. And also, I summarized the data from our study using the hemoperfusion to control the cytokine storm. So actually, it works for the to decrease the cytokine level, to improve the oxygenation, to improve the hemodynamics. So we totally used about 9 patients using the hemoperfusion. So it works.
Sorry, I can't understand the question. Can you tell me, did you try remdesivir?
Actually, this is the randomized trial. So we only we only recruit about less than 10 patients from our ICU. But I don't know which is treatment, which is intervention, which is the control.
Any effect?
I don't know. I don't know. I think the result will come out in the couple weeks. Okay, you mean about the patients get reinfected. So actually, I just have the data from our hospital. I mean, it's only from our medical professionals. We have in my hospital, we have almost 70 medical professionals infected with the COVID-19. So far, 4 medical professionals got reinfected. So, but with your follow-up, these 4 patients, these 4 colleagues, they are no any symptoms. Just quarantine in the hotel.
And others are asking what medications are successful in your practice to treating the patient. Is similar to the other doctor's answer question about remdesivir.
So I don't know any kind of the medication work for this virus. So we still need time. We still need more cases to confirm the results.
So what percentage of the critical?
So actually, in my ICU, all the patients are adult patients. No any pediatric patients. So I don't know how much percentage of the patients are pediatric. I don't know.
There is actually a pretty interesting question. Like, are you using Chinese herbal medicine? 莲花清瘟.
I think it's for the Chinese herbals, it's used only for the mild or moderate cases. So try to prevent these cases become deteriorated. But I never use the Chinese herbals in our ICU.
Dr. Peng, to be anesthesiologist, I'm worried about the intubation when patient in OR. When you intubate, I know you said N95 eye goggle.
Yes.
And also using pepper.
Yes.
PP.
Yes, pepper, yes.
For every patient.
Almost for every patient, yes. Yeah.
Okay. You put another thing to the patient body, trying to create the negative air or whatever.
You mean the?
Because in America,
Yeah.
someone put a plastic
Okay.
bag drip
Okay.
on the patient body.
Okay. Yeah. Yes. We put the plastic bag in the patient body. Yeah.
Another question. You said a BiPAP
Yes.
is not good
So,
for the patient.
so yeah, so be careful. Yeah, depends on the time. Yeah.
So when patient need a higher oxygen
Mm-hmm.
from a nasal or
Mhm.
face mask
Mm-hmm.
to the BiPAP,
Mm-hmm.
how long does it take before you intubate?
Okay, so we will evaluate the efficacy of the any non-invasive ventilation. So if the patients still have dyspnea, still requiring high concentration of oxygen, still complicated with the higher heart rate, and then we think we should switch to the intubation for the patients. So we have a score. I just mentioned the score based on the calculation, based on the respiratory rate, based on the saturation, based on the FL2. So I mean the score is above 3, it's above 3.5. I mean it means the non-invasive ventilation works. If less than 2.5, we think the non-invasive ventilation didn't work. We need to switch to the intubation. So we need to evaluate the patients every 2 hours. Every 2 hours.
Somebody asked, would you recommend early in ventilation incubating patient?
I mean, not. I mean, it depends. I mean, early in ventilation or early ventilation intubation patients. I mean, still depends. So if the patients, I mean, we use the non-invasive ventilation, it doesn't work. So we need to switch to the intubation. So yes, we have a very detailed flow chart for the ventilation support for the COVID-19 patients. So depends on the I just mentioned it. First we try just based on the people ratio. So then we follow up. We evaluate the patient's response to this kind of the ventilation support. If not, we switch to another mode.
I think someone is also trying. Also, this same doctor is trying to kind of reinforce, reaffirm with you like the incubation criteria on COVID-19 patients.
So I mean, if the people ratio, if the patient came to the ICU with the people ratio less than 150, and then we will intubate the patients earlier. So if the people ratio above 200, and we can try using the non-invasive ventilation, and then just follow up the patient's response to the non-invasive. If it respond, okay, go on. If it doesn't respond, change, switch to another mode.
Do you use the PF ratio as a guideline for proning incubated patients?
I mean, we try to prolong the patients as early as possible, as early as possible. And I mean,
so Dr. Peng, do you think that we can let them to ask 2 more questions, and we might need to refresh something that you mentioned with them, with our viewers? So do you guys have more questions? We're going to answer 2 more. We have right here, Dr. May. Do you use a delayed worsening?
Okay,
Do you
okay.
see a delayed worsening of patients after discharge?
So I saw the report about the delayed version of patient after discharge, but personally, I haven't seen any delayed version from our patients.
Let's see. We have another. Do you think that we can wrap up this for now? And if they have more questions, they can email you, or do you think, Dr. Pong?
Yeah.
So I think this is a good point to wrap up. If you have any more questions, please mail to me, and I will pass them on. But thank you again for joining us today and with your.
So yes, Dr. Pong.
Okay.
Yeah. I think they're good. Yeah, Dr. Pong, because my apologies for some, because of the teleconference application, it was not that smooth. So a lot of doctors from the U.S. they actually typed their questions for Dr. Pong, and I'm going to just refresh a little bit because some of our viewers might got lost. So first, because a lot they've been curious about incubation, using ventilators and using ECMO, etc. And you mentioned about this non-invasive incubation, ventilation. Would you mind to elaborate a little bit more, just with the other doctors, etc., watching this live?
Okay.
Yeah, I think they hung it up. Yeah, they end the session. Yeah, but then just about this non-invasive ventilation.
Okay.
You had these criteria about 3.5 and 2.5, and you need to check on patients every 2 hours.
No, every 2 hours. Every 2 hours. So it's easy to check because we based on the respiratory rate. It's easy to detect. Also, we based on the pulse saturation. Put the plot here, and you can see the pulse saturation, easily to detect. And also we based on the FiO2, means the oxygen concentration you used. So that's very important to evaluate the oxygenation after the treatment. So if that is good, is high, it means this ventilation support works.
Yes. But what about some other doctors also asked like reinfections of patients, and you mentioned 7 doctors from your.
No, not 7, 4. Yeah.
I mean 70 doctors.
70.
Yeah.
Infected.
Yeah.
But only 4. Only 4. Only 4. I mean, because this is first, which is mean. What's the definition of the reinfection? The definition reinfection. It means the patient recovered already, and after a couple weeks or after 1 month, so you also detect the positive virus in the patient's body. So it means that it is 2 types, and then we consider that patient is reinfected.
But you give out this number 7 doctors, medical staff in your hospital, general hospital.
Yeah,
70 doctors
infected.
Infected. And
Initially infected, yeah.
But only 4 later got reinfected.
Reinfected,
Right?
yeah.
So what are their conditions right now?
They're okay. No any symptoms.
Okay. So I think that's a lot of things. And about ECMO survival rate, you mentioned about it's right now at your hospital is 40%.
More than 40%.
More than 40%.
Yeah. Around, yeah. I think it's the 40 to 43. Yeah.
And do you think early intervention, earlier replacement of like changing patients from regular ventilators to ECMO will help to increase the it's just to increase. Do you think that will increase the survival rate, like to put on patients?
I mean, also depends on the timing. The timing is quite important.
Mm-hmm.
So if you initiate, the ECMO treatment too late, probably it won't change the outcome for the patients.
Okay, and you mentioned also like right now, just like we don't really have a specific drug for this virus. Like about drugs.
Okay.
Or yeah.
So actually, they have several antivirus medications, so such as the remdesivir,
Mm-hmm.
such as the lopinavir, such as the chloroquine, and also, I mean, from the small study, they show some effects.
Mm-hmm.
But we need more evidence to see how this medication work for the patients with the COVID-19.
Mm-hmm. And earlier I learned from you that for your ICU, for the unit that you are leading, you're in charge, that you treated like about 140 patients, COVID-19 patients, during the past few months.
Yeah.
And the survival rate is 75%, right?
75, yeah.
So what are some of, just in short, like what are some of the tips that you think, because 75% is not a bad number for those critically ill patients. So what are some of those tips that you can kind of grasp from the experience?
Okay. You mean for the tips?
Yes.
Yeah. So I mean, first, I mean, because most of the patients died from the multiple organ failure. So I mean, the initial trigger was the hypoxemia. So if we can improve the hypoxemia, probably we can control the initial trigger to induce the multiple organ failure.
Mm-hmm.
So we have a lot of the way to improve the hypoxemia. So I just mentioned that the ventilation support quite important. So for this kind of patient, so if we can improve the hypoxemia, and then we can control the development of the multiple organ failure.
Mm-hmm.
Yeah, and but mechanical ventilation is double-edged sword, and so we need to be careful about the mechanical ventilation. So we have a strategy which is called non-protective strategy for the mechanical ventilation. So I mean, if you can use the mechanical ventilation well, and then you can improve the oxygenation, and also to prevent further lung injury. Yeah.
So okay, so I think that we're going to wrap up today, and as Dr. Peng has shared with us, like to control hypoxia to worsen, to intervene that process can help with the person's survival rate, and they have this non-protective strategy to help ease patient symptoms. And thanks for watching for this episode, and we're going to deliver more such episodes in the following month. And we know that on April the 8th, very soon, Wuhan is going to lift its lockdown measure But still, doctors are fighting and trying to find a better cure to this virus, and including a vaccine. And thanks for watching. And of course, you can follow us on our Twitter, Facebook, YouTube official account, and of course, download our official mobile application to stay tuned with the live streams episodes like this. Thanks for watching.